Hi, everyone. I'm just giving a moment while everybody loads onto the session. All right, well, I think we can get started. Good afternoon and good morning, wherever it is you are today. My name is Joe Ross. I'm a general internist, physician, and health services researcher who co-leads the Yale-Mayo Clinic CERSI, along with Molly Jeffrey. And I'm delighted today to have two of my colleagues who are going to be presenting as part of the CERSI lecture series on understanding the use of existing real-world data for medical product evaluation. This is obviously a hot topic, as many of us are trying to best understand the appropriate uses of real-world data sources for medical product evaluation, particularly beyond safety. And Drs. Joshua Wallach and Rozalina McCoy have done some really kind of cutting-edge work in this space around trial emulation that they're going to present for us today. Just by way of background and introduction, Dr. Joshua Wallach is an assistant professor with the Department of Epidemiology in the Rollins School of Public Health at Emory University. He received his PhD and MS at Stanford and did his postdoctoral training in regulatory science at Yale, which is how I had the opportunity to work with him for many years. He joined as an epidemiologist and meta-researcher on the faculty at Yale, and just recently left for Emory. He says it's because it's warmer, but maybe he'll talk more about that. Dr. Rozalina McCoy, also another longtime colleague of mine that I've had the good fortune to work with. She's an associate professor of medicine and vice chair for research in the Mayo Clinic Division of Community Internal Medicine, Geriatrics, and Palliative Care in Rochester, Minnesota. She also practices as a general internist and endocrinologist. She's an NIH, FDA, and PCORI-funded clinician scientist whose work leverages real-world data to improve the quality, equity, and accessibility of diabetes care. Thank you both for being here today to present this work, and I will hand off to you. Just as a note before Dr. McCoy gets started, because we're using a webinar, please put questions into the chat, and towards the end of the presentation, we'll make sure and have an opportunity to address them. Rozalina.
Thank you so much, Joe, and thank you for everybody for joining us today. Before I start, just a quick apology ahead of time. In case my internet goes crazy, it is yet another snowy day in Minnesota, and I think my internet is rebelling against that. But the work that we'll be sharing is made possible by FDA support. Next slide. And here is the additional funding that supported Josh's and mine work as well. Next. So the reason that we're all here is really to understand how do we use real-world data to augment current explanatory RCTs, which to date really formed the backbone of providing evidence on device and medication safety and efficacy. And there's multiple reasons for the interest in this. There's concerns for poor generalizability to real-world practice and populations. RCT participants and settings don't represent the real world in which our patients live and in which we as physicians practice. RCTs can't tell us whether and how the interventions that are being studied are going to work in routine care conditions. And as a result, it may be challenging to then implement the findings of RCTs into routine care conditions where they are actually needed. The trials themselves are expensive, take a long time, and are just difficult to conduct. And as a result, 1/3 of trials fail because of loss of study participants, and 85% of commercial trials fail to recruit on time and on target. And because of the expense and difficulty conducting randomized controlled trials, there's often distorted treatment development priorities, resulting in early decisions to either continue or stop treatment development based on limited data. There may be little interest in preventive and long-term treatments for common diseases. And ultimately, there's a focus on expensive drugs for rare conditions rather than the conditions that may need the evidence the most. So, as a result, there's increasing demand for rapid, rigorous, and generalizable evidence to inform healthcare systems learning and address inefficiencies in the current clinical trials framework. So, building on this, the objectives of our work really threefold. We wanted to see whether it's possible to emulate the characteristics of trial populations based on the pre-specified eligibility criteria of ongoing but yet unpublished trials, to similarly emulate the results of those trials, and then compare what we get by in these emulations to what ultimately would be published in those trials. So to do this, we sought to identify two trials that would test a drug that had already received FDA approval and has been available for use for at least 3 years to make sure that we're able to use real world data to study these medications. We focused on products for the treatment of or that influence cardiovascular disease or diabetes. Plan to enroll 500 patients or more in the US, and then focus on outcomes that could be reasonably ascertained from insurance claims or electronic health record data. But we're also cognizant of the fact that we wanted different types of trials to give ideas, to really give us a glimpse into different kinds of outcomes and covariates that could be used, really to generate generalizable understanding of emulating trials. Now, when we emulate trials, we use the target trial framework, which really seeks to apply rigorous, a priori defined um, criteria to observational data as a way of emulating each step of an idealized pragmatic trial. As though this pragmatic trial of those drugs kind of is being conducted under the usual care conditions, right? So with the target trial framework, you can see the target trial in this case, it is the RCT that we are seeking to emulate. That's shown in yellow on top. And then the emulation using observational data is shown in the light blue below. And we work to mimic using statistical methods each step from eligibility criteria using the claims or EHR data to identify conditions of interest, make sure that patients who are included are newly starting the medications that we're studying, identify treatment strategies. The biggest challenge of emulation is the third step of randomization, where our goal is to use causal inference methods to emulate randomization to make sure that the patients that we include in the cohorts are equally likely to get each of the treatment arms that are being considered. We emulate the follow-up period, assess outcomes in a similar way as possible, and then use the analysis plan that is identical as much as possible to that in the emulated, in the target trial that we are seeking to emulate. So next slide. So to emulate randomization, we generally use propensity scores, which is a modeling way of making sure that our patients are equally likely to get each of the treatment arms, because in real world practice, there's usually a reason why a patient is prescribed or given one intervention as opposed to the other. So we use statistical methods in order to balance patients out on measured covariates with the goal of also balancing them out on unmeasured covariates and getting patients who are equally likely to get each of the treatment arms. The data that we use for these emulations is OptumLabs Data Warehouse, or OLDW. It is a national claims database for privately insured and Medicare Advantage beneficiaries. It includes the claims data, include over 136 million lives, and includes claims lab results for about 40% of individuals in claims based on data sharing agreements between OptumLabs and commercial lab companies. There's demographic and information, as well as information on mortality and geography. Now, OLDW also has data for electronic health records for about 83 million people, a subset of which overlap with claims. So for the purposes of our studies, we used claims data with linked laboratory results data. And for those who have EHR data, we included that as well, particularly in one of the trials that I'll mention where we did have to use EHR data. Next slide. Now, for the third aim of our work, where we sought to compare the emulated trials with the RCTs that ultimately got published, we compared them on several characteristics. So first, we assessed we compared the published RCT and our emulated trial with respect to sample size, as well as characteristics of included patients. For the variables specifically, we classified them into one of three categories. Variables were deemed ascertainable if we could reliably and accurately identify those same variables in the claims data. They were partially ascertainable if we could approximate those variables using available data, but we're not certain that it was an exact estimation of what was presented in the trial, whether it's a limitation of the data or because the trial did not provide enough detail for us to be able to emulate, such as providing the estimate of patients who are on blood pressure medications, but not saying what those blood pressure medications actually were. And then finally, variables were deemed not ascertainable if it was not possible to develop a computable phenotype using available structured data. And then for ascertainable and partially ascertainable variables, we conducted pairwise comparisons between the populations in the emulated trial and then the published RCTs. And if the standardized mean difference between them was less than 0.2, we considered those covariates to be concordant. Then for the outcomes, the comparison of the outcomes of the trial, we classified them based on both statistical significance and direction. So our primary classification of concordance postulated that the results are concordant between the emulated trial and the published RCT if their effect size estimates were in the same direction and statistically significant, or if both were not statistically significant, because that means that they're the same. Otherwise, they were deemed discordant. And then our secondary concordance classification looked to see whether the RCT and the emulated trial effect estimates had overlapping 95% confidence intervals. So I'll present our first target trial emulation of the GRADE trial and then hand it over to Josh to talk about our second trial and talk about kind of the lessons learned from this experience. So the GRADE trial was a multi-center prospective randomized open label pragmatic randomized control trial that compared the effectiveness of 4 second-line medications in the management of type 2 diabetes. So glimepiride, which is a sulfonylurea, sitagliptin, a DPP-4 inhibitor, liraglutide, a GLP-1 receptor agonist, and insulin glargine in patients currently on metformin monotherapy and hemoglobin A1C between 6.8 and 8.5%. The primary outcome was time to hemoglobin A1C of 7% or greater while treated with the assigned medication. And that was termed primary metabolic failure. And then secondary outcomes were secondary metabolic failure, which is time to A1C greater than 7.5, as well as tertiary metabolic failure, which is start of insulin, and then cardiovascular and microvascular disease outcomes. The study itself was started in May 2013, completed in April 2021, and ultimately published in September of 2022. In order to conduct the emulation, we used the protocol that was posted on clinicaltrials.gov, as well as the published protocol that the study investigators shared in an earlier publication that was available when we were conducting the emulation, but otherwise all of this was done prior to the publication of the final study results. My personal interest in diabetes is the fact that its outcome was lab-based, and typically it's not something that is considered as emulatable using claims data because labs aren't often available in those data for the claim for subset of the claims population as well as EHR data, which made it possible. It was also interesting because it had 4 study arms allowing for requiring multiple pairwise comparisons with the other emulations. So when we did this, according to the target trial framework, we really sought to emulate every step of the grade protocol. And we applied sequentially all of the eligibility criteria as much as we could in claims data that were specified by the grade investigators. I'm not going to go through each of these in detail, but only to call out the fact that of the patients who initially started these 4 study medications, and you see the ends shown there on the first row, overall, less than 20% of patients newly started those drugs met eligibility criteria for grade. And that varied depending on the drug from about a quarter of patients in the glimepiride and sitagliptin arms to 13.7% in the liraglutide arm and just 4% in the insulin glargine arm. That said, when the grade investigators compared their population to NHANES data to see what proportion of patients would kind of be of the US diabetes population would be represented in the grade trial, their estimate was about 9%. So we actually were able to get even better representation in our claims data. But the biggest reason why patients were excluded, was the requirement for low baseline A1C and insulin therapy. And that is primarily and especially for the glargine arm. And that's going to play into effect soon. And the reason for that is the glargine as an insulin is not recommended that the grade trial was studying it at that level of A1C. So you can see that very few patients met that eligibility criteria. Sorry, now we can go. To the next slide. Okay, so for statistical analysis, we use inverse probability of treatment weighting to emulate randomization. So propensity scores were estimated using the gradient boosting machine method. It included sociodemographic variables, medical history, baseline medication use, and other patient characteristics. We chose the GBM method as well as IPTW because we had multiple comparator arms rather than a single pairwise comparison. And then standardized mean differences were used to assess the balance of covariates. And as we tried to do this, we realized that we were not able to achieve good control of confounders, even after weighting, if we tried to include the insulin glargine arm. And we ended up excluding that arm from analyses because, again, we could not assess the use, we could not identify patients who were equally likely to get glargine as the other medications because the way the glargine was implemented in the grade trial was not the standard of care at the time that the study was being done. For our main analyses, they followed closely what was specified in the grade analytic plan. So the cumulative incidence of primary and secondary metabolic outcomes were estimated using Kaplan-Meier methods, and then we used Cox proportional hazards regression adjusted by baseline A1C and similar to the grade trial itself to compare the outcomes between groups. So this next slide shows compares the populations in our trial versus that in grade. Grade published separately their baseline patient characteristics, and they did not break it down by treatment arm, which is why you see a single column for grade and then 3 separate columns for our treatment arms. So I also want to call your attention to the sample sizes that were being compared. Grade had 5,000 patients overall, about just over 1,000 per arm. And then our sample size ranged from 572 in the liraglutide arm to 4,168 in the glimepiride arm. Patients included in the emulation were somewhat older than those in grade. We had similar racial and ethnic distribution, similar, teeny bit higher, but similar hemoglobin A1C levels and kidney function. And somewhat varied distribution of baseline comorbidities and comparable baseline medication use. So when we compared the baseline characteristics together, there were ultimately 34 baseline variables that were described in the GRADE trial. And here you can kind of see how they compare. So 24% of those 34 were ascertainable. And like I mentioned before, patients in the GRADE emulation were somewhat older, somewhat higher percentage were male. There was more retinopathy and less neuropathy. The covariates in black font are ones that were similar between the two. 41% of covariates were partially ascertainable, and those include education, higher education level in the emulation, somewhat higher use of blood pressure medications. And again, that was partially ascertainable because there was incomplete definition of that variable. Fewer in our population smoked. We had somewhat slightly higher A1C, cholesterol and triglyceride levels, lower UACR, GFR, and creatinine. And then we could not ascertain about a third of the variables, which you can see here, which generally do rely on either patient self-report or electronic health record. And we just didn't have enough of those variables for the whole study population to deem them ascertainable. So here is kind of the drum roll for our actual results. And you can see here the hazard, the pairwise comparisons for primary and secondary metabolic failure for the published GRADE trial, as well as our emulated trial, as well as kind of an indicator of concordance. So whether they were in the same direction, same level of significance, and overlapping confidence intervals. So overall, the results were largely concordant for all outcomes. We found, again, excluding glargine, which we could not include, liraglutide was significantly more effective than glimepiride, and sitagliptin was more effective than glimepiride. So next slide. And here you can see visually comparing the Kaplan-Meier curves for primary metabolic failure in the published RCT, which is on the left, the prettier version, the prettier slide, and then our emulation on the right with just the 3, and you can see them being pretty similar. Next slide. So now I'll turn it over to Josh to talk about PRONOUNCE.
Thanks, Rozalina, and thanks for giving such a nice introduction to both studies and for your overview of GRADE, and of course to CERSI and the FDA for having us today. So I'm going to talk about our second emulation, and we'll go into afterwards some implications there. So this is the PRONOUNCE trial. And this is a cardiovascular safety trial comparing two active treatments, Geriatrics versus leuprolide, in a focus of patients with prostate cancer. So this is an international multi-center prospective randomized controlled trial comparing a GnRH antagonist Geriatrics with a GnRH agonist leuprolide among patients with both prostate cancer and cardiovascular disease. This trial's primary outcome was time to first major adverse cardiovascular event, which was a composite of death, MI, and stroke. Secondary endpoint was each of these characteristics separately. The study was started in April of 2016, completed in March 2021, and published in August 2021. And just like the GRADE emulation, our objective here was to predict the results of an ongoing trial. So we had no idea what the final results were. We had no idea what the population looked like in the PRONOUNCE trial. We were really interested in seeing, without any bias, how we could emulate the trial based upon clinicaltrials.gov information on inclusion, exclusion criteria and outcomes, and any protocol information that was published and available. So while GRADE was very interesting in the fact that it had multiple treatment arms and relied on an emulation with an outcome that had laboratory-based data, we thought the PRONOUNCE was an interesting case study for target trial emulation because it almost looked like a post-marketing requirement that could have been required by the FDA. It was really interested in resolving some safety-related issues, especially in ADT treatment and risks of cardiovascular outcomes. And while secondary studies had looked at comparing Geriatrics and leuprolide and had suggested that patients treated with Geriatrics were likely to have lower cardiovascular risk, there had been no direct RCT comparing these. So again, it was interesting in the sense that it's almost like what would be seen in a post-market study trying to resolve safety issues. So similar to the GRADE one, we implemented the inclusion and exclusion criteria as closely as possible. And here I just have a figure that was just like Rozalina's table, just showing how the sample size changes based upon the creation of the cohort to match the RCT. And you can see it, we're starting with an overarching sample of over 100,000 patients that initiated either one of these medications. And then we narrowed it down to those with demographic information, those with a diagnosis of prostate cancer, and those with cardiovascular disease, again, meeting the specific criteria of the trial. Ultimately, after implementing the more stringent inclusion-exclusion criteria, approximately 24% of all the patients with the indications of interest and receiving the treatment were eligible for the PRONOUNCE trial emulation. So for this analysis, we didn't have more than 2 treatment arms, and we decided, based upon our discussion with the team, to use propensity score matching, which we estimated first using logistic regression and including all of the covariates that we believed were important, those socio-demographic, medical, baseline medical, and patient characteristics. And then checking for standardization between the matched groups to see whether or not the standardized differences were small and that we were actually getting Geriatrics and leuprolide arm patients that were similar. For our main analysis, we use propensity score weighting, Cox proportional hazard regression model, and we compare the primary MACE and secondary outcomes across the treatment arms. So this is a snapshot of a very large table that looked at the balance between all of the characteristics. And it's just to show that we're building this cohort of propensity score matched participants. Our overarching sample here was 2,226. And you can see just for these first characteristics that I have outlined here, that we had well-balanced groups in terms of age, race, ethnicity, geographic region, and this goes on and on in terms of the baseline medical characteristics and treatment histories as well. But this is our sanity check to ensure that we're actually getting something that is somewhat close to what randomization would accomplish. So our comparison of the PRONOUNCE trial and the emulation population. The PRONOUNCE trial included 544 patients of 900 planned. So prior to the publication of the results, the clinicaltrials.gov page outlined that the goal was to recruit 900 participants. However, the trial, we found out after we had completed our study and the trial had been published, had trouble recruiting participants and had trouble identifying outcomes among participants. And I think this is, again, an interesting characteristic that we can get into in terms of what strengths are there in target trial emulations and what are the limitations in RCTs. Emulated trial, as I said, had 2,226 propensity score matched participants, so quite a bit larger. Then we looked at the 31 baseline variables described in the PRONOUNCE trial publication, and just like GRADE, we looked at the concordance and the ability to ascertain these using real-world data. So this table, exact same layout as the GRADE one. On the left column, we have the characteristics in the table that we were able to ascertain using structured data. The middle column, those are the partially ascertainable, and the far right, not ascertainable. And here we have about a third in each of these three buckets, as well as an inclusion criteria that was in the publication itself, but was not listed on clinicaltrials.gov. So here we have some interesting findings that among those that were ascertainable, there was not perfect overlap in terms of what the populations looked like. The emulation cohort was older, less likely to have received radiotherapy for prostate cancer, less likely to have radical prostatectomy, less likely to have a history of MI, less likely to have hypertension. Our sample also included a larger number of Black or African American participants, and on average, they had higher total serum cholesterol, PSA values, and were less likely to receive certain medications. So here illustrating some challenges with identification of these characteristics using real-world data, as well as some differences between the populations that are ultimately studied in randomized controlled trials and those that may be included in emulation cohorts, even when using stringent inclusion criteria to define the cohorts themselves. So this brings us to our findings. Again, a table similar to GRADE, where our first column outlines the findings from the pronounced trial, the second, the emulated trial findings, and then our concordance findings, looking at the directionality, the statistical significance, and the overlapping 95% confidence intervals. So the first row outlines our primary outcome, time from randomization to first MACE, and the pronounced trial had a hazard ratio of 1.28, non-statistically significant, and our hazard ratio was in the same direction, slightly attenuated, and also not statistically significant, fulfilling all of the concordance criteria in terms of directionality and significance, as well as having overlapping 95% confidence intervals. For the secondary outcome, we had concordant findings for both MACE and stroke, but slightly different findings for all-cause death. Now, it's worth pointing out here that the original pronounced trial was going to look at a secondary outcome of CV-specific death, so cause-specific death. However, in our emulation, we were not able to capture cause-specific death, so we focused on all-cause death. When the pronounced trial was ultimately published, it turns out that they also were unable to study CV-related deaths, and their findings were changed, or I should say their endpoint was slightly changed to be all-cause death. These were discordant, opposite directions, and our findings were just on the border of statistical significance. And we suspect that here we have an issue related to studying these drugs in real-world populations and not necessarily being able to identify disease severity and disease stage, and what impact that potentially has on the types of patients that ultimately receive Geriatrics versus leuprolide. So this finding, although discordant, has some concerns in terms of the real-world data. And here's just a similar picture to the GRADE one, showing the figures from on the left, the real-world emulation, and on the right, the publication from the GRADE, the pronounced trial when it ultimately came out, showing overall for the primary outcome, we're not seeing a difference in MACE. So these were our two emulation experiences, again, capturing different indications, capturing different populations, and looking at things that may have different outcomes and inclusion-exclusion criteria to try to get a sense of what emulation would look like in these two settings and potentially be generalizable across other settings in diabetes and potentially cardiovascular and prostate cancer studies. So this big picture, RCTs and real-world evidence studies, or studies relying on real-world data, are capturing different findings. Although we're emulating RCTs as closely as possible, RCTs are really studying the impact of study procedures on the outcome of interest among a very specific and narrowly defined population. As Rozalina outlined in terms of the limitations of RCTs, they often have very narrow, strict inclusion-exclusion criteria that can limit generalizability. And here you're getting average treatment effects among this population that may be fairly narrow. And these real-world evidence studies, or these emulations of RCTs, we're getting the impact of procedures on outcomes in potential stakeholders in the general patient population. So thinking in terms of potentially enhanced generalizability and what's being conducted in the usual care conditions. But overall, our study highlights a number of challenges, although we were obviously pleased to see that overall our findings were in the same direction and often were similar in terms of both direction and statistical significance. This doesn't mean that this was straightforward and that future emulations will be straightforward as well. One of our primary challenges was clear from the figure with all of the red highlighted discordant and non-ascertainable characteristics was that it's challenging to ascertain eligibility criteria from insurance claims and electronic health data, especially those that are structured. And we've seen this in some of the previous work that we've done, that trials rarely have all inclusion and exclusion criteria that can be routinely and feasibly ascertained using contemporary claims and EHR data. So this could make it challenging to actually emulate an RCT that's exactly like the RCT itself, rather than potentially modifying certain inclusion-exclusion criteria or characteristics and getting a trial that may be more generalizable and may not be as narrow as the RCT itself. We also have this issue that laboratory values are only available for a subset of the emulation trial cohort. So for example, while the pronounced trial had PSA values, these were only available for a subset of the overarching population. So it's difficult to conduct these emulations when not all characteristics that are important to balance across groups are available for all participants. Another issue was that emulations are not able to account for the differences between how medications are used in clinical practice and how they're used in RCTs. We saw that in the GRADE trial with the exclusion of one of the arms that was not really reflective of contemporary clinical practice. But we also saw that in the pronounced trial where we weren't able to account for prescribing differences that there may exist between Geriatrics and Leuprolide. This next one is maybe a little bit of a gripe that we had while we were conducting these, is we were trying to do this before any of the information really about the final publication was available. But relying on information in protocols and clinicaltrials.gov may not be what's reflected in the ultimate study and publication of the RCT. And we found cases where there was either a lack of information, for example, what type of drugs were considered in terms of inclusion or exclusion criteria, as well as changes in some of these characteristics between what was outlined and proposed. And these things can make it difficult to compare the findings and populations from RCTs and target trial emulations, because there are changes that are happening that cannot be controlled. And we've matched our emulation to what we believe to be the procedures used. Another issue is that, again, statistical analysis plans for an RCT can change over time, and they're not always consistent updates. So these two are kind of paired together. And the last one is more of a big picture challenge rather than a challenge specific to our study. Should we actually expect the same results from RCTs and emulation trials? Although emulation trials may play a role in terms of complementing the findings from randomized controlled trials, they're not really capturing the same populations, and given that there are differences in terms of how they're designed and analyzed, it may not always be feasible to expect that we would see alignment in terms of both directionality and statistical significance. But despite some of those limitations, there are some key strengths that I think our study demonstrated. Overall, compared to some of the statistics that Rozalina outlined, target trial emulations can be conducted at a fraction, and a fraction is an underestimate of the cost of traditional RCTs. So this is obviously a clear benefit in terms of generating evidence, as well as a fraction of the time. We conducted these target trial emulations within a 2-year period, generated results prior to the publication of the findings of the trial themselves, and we were able to reflect contemporary use or actual use in the real world, while some of the trials that had been designed in 2008, started in 2013, and eventually published in 2022, may no longer reflect the realities of care. Another advantage was sample size. In pronounced trial, we had a difference of nearly 1,800 patients in the emulation cohort versus the RCT. And even in the GRADE trial, which was a giant RCT, the emulation cohort had a larger sample size for the arms that were able to be identified. Another strength here in our evaluation and use of OptumLabs data was a solid range of characteristics and endpoints that were captured. Despite the challenges that we encountered in emulating the exact inclusion-exclusion criteria, we still had a large range of characteristics, as well as both clinical laboratory measures and claims-based measures that we could capture using reliable and validated algorithms. Another strength is our reliance on the target trial framework, conducting these analyses using well-defined methodology and following these procedures and framework in order to, as closely as possible, emulate what randomization would have an impact on a population. And another strength is what we hope is improved generalizability, that our findings may include a larger proportion of racial and ethnic minoritized groups, greater proportion of older adults, and outcomes that reflect not a narrow clinical trial population, but a broader population, even when we're implementing the inclusion-exclusion criteria of these trials as closely as possible. So this brings us to the overarching kind of takeaways. We were pleased to see concordance in our findings, but again, our challenges suggest that these emulation trials are likely to serve as at least right now as a potentially a complement to RCTs, rather than a necessary replacement, given that, across many cases, specific characteristics related to disease severity and inclusion-exclusion criteria may undermine exact replication or exact emulation. But that being said, they can provide more timely, less expensive, or larger evaluations of drug effectiveness and safety in real-world populations. The notable challenges that I discussed is, beyond our study, there are no perfect data sources to conduct trial emulations. There are strengths and limitations across these, although we believe that ours was well designed to rely on both claims and electronic health record data. Variable and endpoints cannot always be ascertained, and these will depend on the real-world data source used. RCT and real-world populations are inherently different, and we may not always expect them to find the exact same outcomes, and it may not always be appropriate to compare them. That being said, rigorous analytical methods required to do this work, and it will be important to continue to monitor ways that real-world evidence and target trial emulation can inform decisions that are being made and complement the evidence that we're getting from traditional RCTs. So this is opportunity for, there are two people presenting here, but this was a tremendous team effort. This would not have been possible without the FDA and the Yale-Mayo CERSI, our fantastic team of analysts, statisticians, subject level expertise, and the CERSI co-PIs, Molly Jeffrey and Joe Ross, for giving us the opportunity to lead this work and to collaborate with fantastic team, as well as our collaborators, Charu and Kenneth at the FDA. So thank you all, and looking forward to discussing.
That was terrific. Thank you both. And I saw that some questions have come in on the Q&A. But maybe before we turn there, one of the things that I just want to call out to make sure that everyone who's listening realizes is, while there's been a number of studies now that have taken this target trial emulation approach to replicating studies, as far as I know, this is among the first, if not the first, that emulated ongoing trials before the results of those trials were available, which is really interesting and novel. It creates removes the bias effect. But also what's notable, of course, is the use of the structured electronic health record laboratory value data, particularly as endpoints. So for the pronounced trial, it was used to characterize the population, but for the GRADE trial, it was the endpoint. And when you kind of take a step back, while kind of in general, the results were similar between the two, when you actually look at the confidence intervals for the pronounced trial, they overlap. But for actually, you could say for 3 of the 4, because one arm wasn't even ascertainable, Rozalina, that confidence intervals don't overlap. And I'm wondering if you have any comments on when we're thinking about emulating trials with real world data and the use of laboratory data, which aren't collected in a standardized every 6 months like you would in a trial, kind of what's the impact of that?
No, I think that's a really good point. I think when we were emulating the GRADE trial, there were many things that I think there were many great examples of both the limitations and strength of using real world data for this. Because so for labs, there's a lot of variation in how frequently and when patients get their A1C measured. And that's influenced by both by confounders of what their glycemic control is, patients' access to care, all things that also influence the outcome. Plus, there's some random variation of just the labs that we have access to that are available in the data from amongst those that are collected. And we were both facing the reality of the clinical practice, which is highly variable and very different from clinical trials, as well as the fact that what was being tested with glimepiride is not happening in contemporary practice because it's not the standard of care to use insulin in patients with A1C, of 8.5 or less as second-line therapy. It also required a very specific patient population to be included in the GRADE trial. I mean, they had to be willing with an A1C that is pretty much at goal to be subject to insulin therapy, which most patients would not want to do unless they had other reasons for wanting to participate in the research or the trial. So I think when we compare the results that we got with those of the GRADE trial, I mean, you can see that liraglutide looks a lot more effective than glimepiride, for example, based on the hazard ratios. But that's, I think, a lot factors contribute to it, including the fact of who can access liraglutide, which is very expensive in the real world. So maybe those patients have other reasons why they are doing better. Maybe we can capture their lapse better. So I think when you think about what additional evidence this adds to the trial, I think it really highlights what is happening to people who are using these medications in the real world, as opposed to kind of that idealized setting where you can force your trial participants to do things that they would not do as part of routine care.
That's great. There's one question in the chat that Rozalina, you already answered, but I think it's useful to sort of say out loud. There was questions about selecting variables when performing the IPTW, and did you use them all potential confounders, and how to select models, and if you just want to address that, it's part of it.
Yeah, this is also, I wish that some of our biostatistician experts, especially for the GRADE trial, I don't know if Eric is here, to potentially respond as well. But I think so when we're choosing the variables for the propensity score models, we really used a combination of clinical insights and published literature to identify likely confounders and kind of think through what is likely to be an effect modifier versus a confounder. And then we do include all that we think are clinically important and likely correlated, both with the likelihood of treatment assignment and the outcome. So we kind of include both. We don't use high dimensional propensity scores where kind of the model selects those variables for you based on what's available for a number of reasons. I mean, those methods haven't necessarily been shown to be superior, and trying to do it on a database of OptumLabs' size would just be technically very challenging just because of how much data we have and not. And that actually informs a little bit of the types of models that we use, because some of the more advanced models, they just require a lot of memory. And when your sample size is, over 6 million to start with, that can be very challenging just operationally. So I think that determined some of the modeling approaches. And then also looking at, what is the type of outcome that we have. what does the data look like, and having guidance from our biostatisticians who have a lot more expertise in this than I do. But I don't know if Josh, you have thoughts as well.
No, I think this, especially for grade, which was, far more complex than treatment A versus treatment B in pronouns. I think you're absolutely right, is that the decisions in terms of number of treatment arms and what propensity score balance was going to look like informed these decisions. But yeah, I'm not sure I have too much to add to Rozalina, what you've already captured.
There's an interesting question in the chat that asks, have you come across situations where real world data does not reflect the RCT, and can you use the emulated trial to account for why that is so? I think what the question is getting at is, can you test the inclusion or exclusion of certain eligibility variables or other variables that might control for specific confounders or not for others, to try to sort of get to the quote unquote answer that was seen in the trial versus the answer that was seen in, when taking kind of an observational look at it. Can you think of examples where this is so and how that might have happened?
So we did not do that in this trial, but I know in prior work by our colleagues, so Drs. Yao and Noseworthy, they did something very similar when they were looking at, I think, atrial appendage ablation procedures, and they did that because the results that they got in their emulation, which was done after trial publication, but they got very different results initially. But when they really looked at the different subgroups, they were able to kind of understand why. And a lot of that is driven by the strict eligibility criteria of patients included in the RCTs, as opposed to those that use those medications in the real world.
Yeah, no, that was my memory too. There were certain patients who were included in the sort of identified as if they were eligible in the real world data or observational data sources, but they were not being operated on, or they were not being, they weren't considered eligible for procedure within the context of the trial. And once they were able to exclude those patients, their point estimates actually ended up matching up. And that was actually my memory of, was it the hormone replacement therapy too? There was some kind of, in order to sort of emulate the trial, to change the eligibility criteria to make them match, and then you get the same answer, so to speak.
Yeah, but that was actually partially why we wanted to do this before the results were published, in order to avoid kind of that bias. Mm-hmm.
Josh, I wonder if you could just speak for a minute. I mean, one of the interesting things about the PRONOUNCE trial is in many ways, it emulates a post-marketing requirement study that's done for safety purposes. Yep. And sort of just to sort of restate kind of like what made it, what like how you think these types of data sources could be used. I mean, obviously, real world data sources have been used for safety for 20 years, right? And, but I think the methods are advancing, and of course, the data are getting more advanced.
Yeah, I think this was an interesting part of this PRONOUNCE study is, what potential implications or what role could something like, target trial emulation play in, two areas that the FDA has potential interest. One is post-marketing requirements. So for drugs either receiving accelerated approval, and there's a need to kind of study long-term efficacy, or drugs approved with post-marketing requirements for safety once these drugs have been used and are available, actually relying on the real-world data to study long-term adverse events. I think what's interesting is this was a really nice example of a treatment, like active treatment comparator study with the safety outcome of a drug that had already been in use, addressing a question that had not been addressed in previous studies, and thinking about an unknown. We've previously looked at, what would be some of the challenges with using real-world data to inform, post-marketing requirement studies. And I think, part of what we learned here in this study and what we learned in our other evaluation is that there may be a role for the real-world data and the combination of target trial emulation to, inform how drugs are working in the real world. But the challenges are with identifying the exact same patient population as the initial approval. So the ability to capture the narrow populations for many approvals that require, disease qualifiers or disease severity, as well as the stringent inclusion-exclusion criteria, I think that might undermine the use of the evidence for post-marketing requirements. But it does show that potentially, these studies with less strict inclusion criteria or more general populations that are ultimately going to receive the treatment rather than the potentially narrow, like label-specific indication, there could be a role for this. And I think the PRONOUNCE trial demonstrates some of these challenges, as well as some of the strengths in terms of, population and sample size.
Another question from the Q&A that I think relates to the point that you're making, which is, have you identified types of RCTs that are more suitable for emulated trials?
Absolutely, yeah, and we're actually actively talking about, like, I've been kind of thinking about this today even. There are challenges, and you'll see in the literature of target trial emulation, you'll see cardiovascular outcomes and diabetes outcome trials. These are often the types of studies that are emulated, given the feasibility of emulation in terms of the characteristics that are important, the interventions, the comparators, the inclusion-exclusion criteria, and the outcomes. You don't see as many in oncology, where you need very narrow and well-defined indications, and your inclusion-exclusion criteria, at least using contemporary claims and electronic health record data, would be challenging to create the same cohort. And other areas where you don't see as many would be autoimmune diseases and neurology. So I think, part of what we've seen in these two examples and some of our other work looking at the feasibility of conducting these is that there are certain areas where these emulations may be more realistic immediately in the cardiovascular space, and there are areas where there need to be more standardized data models to conduct these analyses with a focus on oncology or neurology, or some of these fields where you might get a larger number of accelerated approval drugs with unclear evidence at the time of approval, or unclear long-term clinical benefit at the time of approval, or something where you want to look at safety. So I think, big picture, we're seeing more in cardiovascular studies and not as much in some of these areas where you have narrowly defined populations that require really specific quantifiers to identify the exact population.
Yeah, no, I think that's a good point. It's worth remembering that, when the standard in the clinical trial literature for a given clinical area is like a patient-reported outcome measure, or maybe it's a biomarker that's based on imaging, right? Those are very difficult to emulate from a structured data model, right? You're not going to be able to know kind of a depression severity score or a response rate in cancer. So I think we have time for one more question, and I'll ask, are you aware if there have been any emulated RCTs to evaluate the effectiveness of interventions in public health emergencies, either pandemics or regional outbreaks? And having just been through a pandemic, this obviously seems quite relevant.
I don't know if Rozalina wants. I have not. There's a difference obviously between traditional observational study and the target trial framework, where you're trying to target an exact RCT. Using the target trial framework, I have not seen any, but I will say that this question has come up from my colleagues here and other times where I've discussed this, is that there may be opportunities to rely on this framework when considering using observational data in other settings. But I personally, and not an expert in all fields, have not come across these, but I could be completely wrong. Rozalina, have you any additional thoughts?
No, I agree with you. Sorry, I was actually verifying the other question about whether there was an error on the gray trial slide. But thank Joe for answering that too, because there was, but no, nothing else to add, Josh.
Well, I just want to take a moment to thank you both again, not just for being such great colleagues, but also for leading these projects and doing such a great job writing it up. It's just for people who are interested. The PRONOUNCE emulation was published in JAMA Network Open. The GRADE emulation was published in BMJ, and there's now a paper that we have under review that we can send out to those who are interested when it gets published that actually does a formal comparison, essentially summarizing a lot of what was presented today. So thank you to the FDA and to the CERSI program for giving us this opportunity to present work from our specific CERSI, and I hope everyone has a good day.
Thank you so much.
Thank you.